beginning. I'm just going to make a start at this point, just so that we get through the material within the timeline that we have allocated. If someone joins us a little later, we'll just bring them up to speed. So one of the things that I spoke about in the class earlier this week is that I'm always trying a few different ways of what can we change and how can we make the design of the course to work even better for you. And as the pandemic happened, we moved everything online. So I think that a lot of our live online sessions have been mirroring quite closely what it would have been or is in an actual classroom setting. And since this group that you're part of, we're meeting also in person and then having these virtual live online settings, one of the things that I do want to avoid is having redundancy of kind of covering similar material in a similar manner. So one of the things that I shared with you in the class was that I've decided that we're going to try these Wednesday sessions to have a little bit more of clinical perspective. So we're going to look much more pictures and work from those pictures almost as a review session of everything that we have discussed in the classroom, and everything that also things that we haven't had a chance to discuss in the classroom that we want to cover as part of the lecture material for each chapter. I have also shared with you that we have been doing these already for a while, these review sheets for each chapter about some of the key structures and physiological processes. So I'll make sure to have time on a side that we get to revise through that as well, in case you were not able to catch that quite at the during the session. I think that we got through the anatomy portion of the respiratory system really well, but we have a little bit more to look at when it comes to the physiology. So having said all that, kind of sets the scene for what I was hoping to do today. And I teach a lot of different kinds of groups. And some of the groups that I teach are more mature students. They already have careers going on in healthcare field, and they're looking to take their careers to the next level or a next role in that field. So for that reason, I sometimes get questions that I think are really insightful and really good that I wouldn't think myself, that really helps me to bring in a different angle than I probably would think myself. So that's what I'm hoping to do every once in a while. And for example, with this opening discussion that we have. So I have quite a few students who take care of older people. And some of the questions I've received has been that we know that smoking is bad for you. And smoking is especially problematic or challenging for an elderly patient. And how can we as healthcare professionals help these elderly patients to deal with giving up smoking or dealing with the issues that come with the cutting down on smoking? So I want to take a moment to talk about that. Of course, I'm sure that this is not going to be a surprise to anyone. Smoking is not great for you. And here I have a picture of a non-smoker lung and a smoker lung, and you will find a lot of similar pictures all over the internet, and you can find the one that really works for you. But often as a student myself, and then later on as well, I looked at these and I was like, okay, maybe this is just more for the shock value. But I can confirm when I conducted my first postmortem on a heavy smoker who had been a lifelong smoker. I don't think that they were much older than 40 years old. There is a distinct difference in the lungs of a non-smoker and a smoker. And I think that, just to share a personal story, I think that once I did get to the chest cavity, exposed the lungs, I threw up a couple of times. Of course, not within the vicinity of the caviter, but that really hit it home for me, the effects that smoking does. And I think that that was the exact moment I stopped smoking myself. So maybe that hopefully tells you that I come from a good place. I have been there myself, and I have seen the consequences myself, and that really convinced me that there's something to be changed. So although it is widely acknowledged that smoking is unhealthy, smoking often tends to play an important role as an activity in the seniors' lives. What I'm noticing is that whereas smoking was kind of a, I hate to use this word, but it was kind of a little cooler with the previous generations, this current generation is actually doing really well and really kind of looks down upon on smoking as an alternative way of passing time or entertainment activity or so on. But we have to remember that seniors go back much more than the current generation. So we do know that smoking is bad for you. But why is smoking so detrimental for your health? Well, really the simple answer, I guess, is that lungs are not designed to cope with the smoke instead of the air. And there are so many toxins in the cigarette smoke. And it is these toxins that make this especially problematic for us. When we talk about smoking and with seniors, it is worthwhile to note that smoking is a habit that's not just bad for the seniors, it's also bad for their caregivers. So the secondhand smoking is really a significant issue that I do want us to acknowledge that exists, and we should probably spend a little bit of time recognizing that it's not only you that you put at danger, it's everyone else around you as well. And secondhand smoking, the consequences, the effects of that are far more severe than we have traditionally thought it would be. So some of the reasons, I was working through this issue with some of my students, and some of the reasons that I think really contribute why it's especially hard to stop smoking for elderly patients is that it is a nostalgic reminder of when you were younger. And that might play a role. And as you age, and especially towards the later stages of your life, you do lose some of the control over your own life. You need help with due to medical reasons, but also with sometimes day-to-day activities that you used to were able to perform without any assistance. So smoking might be a way to cope with that being uncomfortable, or just in general losing that control over your own life. So it might be one of those things that there's much more greater psychological reasons for smoking. So just the health facts might not be enough to convince someone of an older population to change their mind. And we do have to recognize, and I say this as a former smoker, I'm very lucky that I stopped smoking quite a while ago, but former smoker, it is simply an addiction. And kicking an addiction is tough. The good thing about stopping smoking is that the changes that you see, the positive changes that take place after stopping smoking, are really fast. Within hours, we start to see some of the first physiological changes. And within a year or two, the lungs really have recovered drastically. So it always pays off to stop smoking. So we don't really get that excuse that, oh, I've smoked so long or such a long time that it's not worth it. It really is. If we think of some of the reasons why stopping smoking can be especially hard for the elderly, we do need to remember that the sudden absence of nicotine, which is one of the addictive ingredients, one of the ingredients of cigarette smokes, if you move away from having a constant amount or a certain amount of nicotine in your body, and that's suddenly absent completely, that does have physiological effects as well. So it causes elevated heart rate and blood pressure to be elevated as well, and also certain nervous issues. So we really do end up seeing physiological changes, withdrawal symptoms. So that's something to keep on mind. Another way that I think that was actually a very good way of explaining the sensation and the effect of being drunk. And this was a neurologist who explained it in this way, that every time you're drunk, you're actually going through a poisoning state of your of your nervous system. And that's quite drastic if you think about it. You are going through a poisoning. So similarly, we can't just say that, oh, smoking is the only bad thing. There's many, many bad things that I would even go as far as to dare that if you were trying to introduce some of these substances that we use recreationally these days, I don't think we would get them as common, and I don't think that we would declare them illegal much more easily with the current knowledge. And that doesn't just go to alcohol and smoking. I would even go as far as say that we might have to consider, could that happen with sugar and additional sugar, added sugar on products? Sugar is addictive as well. But back to smoking and effects of smoking on seniors. So seniors in particular are especially prone to the negative health issues that arise from the inhalation of the smoke. And this is due to their advanced age and also their reduced ability to heal and resist diseases. So it's almost like a double whammy, that not just that it is a long-standing habit. Now we have this longer pattern of dependency, if you wish to use the word addiction, to the cigarette smoke, but also the effects of the cigarette smoking are much more drastic on the older population. So how can you stop? Quitting a habit is difficult for anyone, and for seniors who may have smoked for decades, that might be especially challenging. I do wanna point out at this point that some of the medication-based aids for quitting smoking are not going to be appropriate for seniors. So we have also that problem to consider. So one of the best ways that literature tells us, the best ways to quit is to replace smoking with a healthier habit. For example, chewing gum is excellent. So it gives you that satisfies the craving to have something in the mouth, especially after dinner. So remember, digestion starts at the level of the mouth by the saliva. So often you do see smokers saying that was a good meal. I'm going to enjoy having a good cigarette after that. That might be pairing up with the digestive processes and promoting those digestive processes. But also it is these chewing gum, for example, as a kind of a healthier habit, can help to take the mind off from the nicotine as well. So replace one habit with something that's less harmful for you. Another option would be, for example, a piece of sugar-free candy or another favorite treat. So again, we don't want to go from one bad habit to another bad habit, but if it is a candy and it helps you to kick off smoking, it probably is one of the downside effects of consuming that candy, as long as we keep within check. So to kind of wrap up, I do want to talk a little bit, since many of my students were, and I assume that even now many of my students are caregivers. So why caregivers are especially well adapted to deal with helping individuals who are smokers, older generation who are smokers, to deal with this habit and kick off this habit. Well, first of all, caregivers are able to keep an eye of their patients much better than you could, for example, in a hospital setting, what nurse can dedicate the time for an individual. And caregivers, really, you can remind someone why they are quitting in the first place. So you might be that positive angel sitting on the shoulder, reminding it's your conscience speaking. You are trying to do this, and remember all these great reasons why you're trying to stop smoking and move to a smoke-free lifestyle. Caregivers, one of the things that I really admire about caregivers is that they are trained to be tough when needed, while still maintaining that caring and compassionate demeanor. So really, I think that caregivers make perfect addiction counselors. So I'm not saying I want to add more on your plate. Caregivers typically are underpaid in relation to the job that they do. That's my personal view. But you do have so much of the skills of the addiction counselors. So that might be the next step on the career to consider. You already come with a wealth of knowledge. As for the potency of the cigarettes, well, we know that unfiltered cigarettes are the worst. So doing your own cigarettes, wrapping them up, not putting a filter, that is a real whammy. Manufactured cigarettes do have advertised nicotine and tar rating. So these chemicals must be, or certain chemicals must be used to lower the nicotine and tar in the tobacco to the advertised levels. What's interesting, or what's of course worth of noticing, is that however these chemicals do still remain there, we're just lowering the levels, and we're doing that chemically. What's interesting and kind of saddening is that what nicotine and tar is removed from the cigarettes in this process is often sold as a pesticide. So we're really taking something that's super harmful for you so we can sell it for you, and we're using that super harmful as a pesticide. So really, I think at least for me, it makes me stop and consider that, is this good in the first place? Well, now that we have spoken about smoking, I think it's a perfect time for us to step back to the lecture material and have a look of a little bit about kind of walking through the structures that we have seen, some of the physiological concepts, and taking it from there. So what I have here next is a really nice diagram, a mid-sagittal cavitary dissection of the nasal passage. So we're going to be focusing initially only on the nasal passage, nose, nasal cavity. We'll continue a little bit further later on this session. But of course, I asked you in the classroom that what is the structure that most air enters through? And it was, of course, our nose. So most anteriorly in the nose, you remember we had hairs, and the function of this hair was to really filter the largest particles from the air that enters to the respiratory passageways. We do want to remember that some air can also enter through the mouth, so through the oral cavity as well. This is usually when we need to increase the volume, and we might need to increase also the speed of entry of the air to the cyst. So this usually serves some sort of a purpose that we're not meeting the needs as is. But if we get the air in rather through the mouth than the nose, we do lose. That's not an ideal option. We do lose out on certain things. We do not end up filtering or heating the air in the same manner as we would if we were to get it in through the nose. So what we're seeing here is, like I said, a mid-sagittal cavitary dissection. I think it's a beautifully dissected, so we're going to refer to that on few occasions. And we also see endoscopic images. And what we see on the first image here, let me just change the tool. We see a swollen turbinate, and we see how pale this mucosa is. So this is a patient that would not be doing well. We remember that the nasal mucosa was very thin. We had a rich blood supply underneath there. So we would expect the mucosa to be much more reddish in color. We are typically able to see more of that blood supply right underneath it. And of course, this really swollen turbinate conchi, that's a concern as well. So rather, I would say that the second image that we see here, this endoscopic view to the nasal cavity, is probably much more normal looking, at least for what I would be looking. The turbinates are not protruding as extremely, the color looks much better, and so on. So let's talk a little bit about the nasal cavity and some of the first structures that we're gonna see there. So first of all, we remember that the entire nasal cavity was lined with our nasal mucosa. And the nasal mucosa, you remember, it was the goblet cells that secreted the mucus that played an important role here. So this really served the three functions that we had for the nasal cavity that were really important, that we kind of wanted to highlight. Why do we have all of these adaptations that we saw with the nasal cavity? So first of all, we wanted to humidify the air entering. So the air that enters to the respiratory tract, we want to make sure that it's much more humid than the air typically around us is. So we noticed this, for example, when you take a deep breath of cold, dry air on a winter's day through mouth, so we don't get to go through this humidifying that air before it enters to the respiratory tract. Often you end up coughing away. So nasal cavity plays an important role in making that air humid enough before it enters further down the respiratory tract. The other reason is, of course, as we kind of already touched upon, the heating. Heating the air. So we want to make sure that the air is not too drastically different temperature from what our lung structures will be. So this is where we start to heat up the air that's going to enter to the lungs at the nasal cavity level. And of course, we talked a little bit about this when we talked about the hair at the anterior portion of the nose. But mucosa as well, you remember it's sticky. So it helps to trap any particles that don't get filtered here within the nasal hair. So any smaller particles or particles that might just escape it. So that's the other important reason why the air typically passes through the nasal cavity. So we really hit those three things. You can think of in terms of the filtering, that is the first line immunological defense that we talked about. So these mucus-coated membranes include also immunoglobulin A that then helps us to fight against pathogens. So these were the three important functions that really the nasal cavity, the first part of the respiratory tract, allowed us to deal with. I do want to point out from this diagram another thing, and I'm going to see if I can remove a little bit of a drawing that I've done, and it looks like I was able to. I want to spend a moment talking about a few other structures that we're seeing here. So let's talk about the conchi a little bit. So conchi are these protrusions from the wall of the nasal cavity, the lateral side of the nasal cavity. So really we saw these on these endoscopic images on a side view. They kind of come out of the wall as these little expansions. And these conchi served an important purpose, tying into the three roles that we had for the nasal cavity already as it is. So first of all, let's have a look of, since we have three conchi, we named them based on their location. So we have superior, middle, and inferior conchi. And what they do, they increase the surface area of this mucous membrane lining. So again, as more surface area means that we have more area to do all of these three important functions that we talked about. In addition to the increased surface area thanks to the conchi, another thing that conchi do, they do generate air turbulence, so that we're able to get a maximum amount of the air to get in contact with the mucous membrane. So that's an important characteristic that we kind of want to keep in mind, that not only they give more surface area, they ensure that as much of that air passing through this nasal cavity actually gets to get into contact with the mucous membrane line. Just as a side note, kind of one structure that we mentioned before in the class, and we haven't really spent too much time on that. I just want to point it out from this diagram. What we see here is the opening of the auditory tube. So this is the anterior opening of the narrow passageway, sometimes called also Eustachian tube or pharyngotympanic tube, and that comes from or runs to the middle ear. So we have that connection from the nasal cavity to the middle ear. And that was when we had the pressure difference between outside and inner ear. We want to balance off that pressure difference. So this tube plays role on that, and all those swallowing actions that we talked about when you're for example, climbing to a different altitude on driving or on a plane or so on and so on. So we've seen quite a bit on this diagram. There are, though, a couple of other things that I think that we can also highlight. So we talked in the class about having a hard and soft palate. So you'll notice how the anterior portion of the roof of the oral cavity or the floor of the mouth actually has bone inside there. So that's why we have the hard palate. And then more posteriorly, we have the soft palate. And you'll also notice how the very posterior portion of the soft palate gives rise to the uvula. So hanging bit at the back of the mouth. And we'll talk much more about that and its role in the swallowing reflex, sealing of the nasal cavity, and so on as we talk about the digestive system. Another thing that's quite interesting on this picture, you can see the tongue. You'll notice how large tongue really is, the muscular mass there at the floor of the mouth. And much bigger than what we typically see when we just look from the front of the mouth inside to someone's mouth. There are, though, one more structure that I really do want to emphasize and talk a little bit about with you. And I'm looking for a different color. I think we can make it work with this. So you remember our pharynx, and pharynx could be divided into 3 different parts. So let's start with our nasopharynx. It's not really showing up nicely, so I'm gonna just change the color. Bear with me. So our nasopharynx covering the region immediately behind the nasal cavity. So that's the most superior portion of the pharynx, if you wish. The next part that we will see is going to be named again after the structure that's immediately in front of it. So we're going to get our oropharynx. And again, I'm just going to use a different marker to highlight that it's not really showing up the written text especially. So we have our nasal and oropharynx, and then the third portion, again, not too surprising with the nomenclature, the naming system that we use, it's above the larynx, so it's gonna be our laryngopharynx. So really, it's the laryngopharynx that's the part that, and it would be the oropharynx as well, where we are sharing the passageway of the air and food. But nasopharynx is the only portion where it's only air that's supposed to pass through that. And of course, we are going to be looking at the larynx a little later, discussing the voice box, the importance of that and structures that we can see there. But what I have here next for us is actually a rather nice coronal section. So again, remember our terminology. And in this coronal section of an individual, we can start to see a lot of the structures that we have talked about. And it's really worthwhile to take just a moment. So first of all, we see our nasal septum separating the right and left side of the nasal cavity. Another thing that we're seeing really nicely here are gonna be these nasal conchi. So coming from the wall on the lateral side of the nasal cavity, how these nasal conchi are probably bigger than we instinctively end up thinking for their size. On this one, I think we only see the middle and inferior one, but still worth noticing. We can also see the hard palate, so the bony structure there, separating the oral and nasal cavity from each other. What else could we see? We see our maxillary sinuses quite nicely there. And if we go a little bit further, we're still seeing those maxillary sinuses. But now, if you look very closely here, we're starting to see also our olfactory bulbs just below the brain. They're above the nasal cavity. So this is where the sense of smell that's often associated with the taste sensation that's perceived, so a direct outgrowth of the brain. What else could we see? We're starting to see probably submandibular glands here inferiorly, quite nicely, just next to the tongue. And of course, we see our masseters, these big muscles of mastication that take a prominent role there. Let's continue our journey. And we are starting to see sphenoid sinus. I realize that this is getting a little busy, this picture, but here we're starting to see the sphenoid sinuses and just above the nasal septum. And we're also seeing a little bit of the ethmoid labyrinth that's going to be taking the space there. I'm trying to see what else nice things could we see. I think we can start to see also the parotid ducts on the left-hand side, just lateral to the masseter, bringing the secretions from the parotid gland that's located here next to the ear. So a lot that we can see there. We have here MRI pictures of both coronal and sagittal section of the nasal cavity. Quite nice to notice. We see a lot of these structures that we've already talked about. And what I want to take a moment about is to talk about sinuses as the next structure. Here we have an X-ray picture of the skull, and you can see the really prominent dental fillings, probably amalgam fillings, metal fillings. They are showing up nicely. But we can, if we have a good screen, we can start to make up from that skull also those sinuses that were the empty spaces, if you wish, within the skull. So let's have a look of those with few different views. And I'm just going to remove the writing that I had there. That's going to make it a little bit easier as we work our way through. And let's have a look of the different sinuses that we can spot from here. So first of all, we can see our maxillary sinuses within the maxillary bone. You see, I've outlined the outline of these sinuses on our diagrams just simply because the screens are not always that great. You might need to have a medical grade screen to tell out the difference. So I try to highlight the boundaries. But we do see our maxillary sinuses there within the maxillary bones. So these big pronounced sinuses. Let's have a look of our frontal sinuses. So frontal sinuses, of course, within the frontal bone on both sides, above there where the eye sockets are, empty spaces there. It really pays off to pay attention to both of these views so you get more of the three-dimensional character of these showing up. What I have next here, and it's only really visible really well on one of these, is going to be our sphenoid sinus further deep in to the skull within the sphenoid bone. And then we had the ethmoid sinus, or you remember that I tended to prefer to call it ethmoid labyrinth because of the fact that it is so much of an interconnected sinuses that forms this structure, so that we end up finding as well quite nicely. So we do see these same things that we've discussed in the class, and I think that one of the things that would be worthwhile to note is that we should quickly revisit. These are continuous from the nasal cavity. They are lined by mucosal lining, but why do we have And we remember that we had explanations of different levels of, I don't want to use word credibility, but different levels of support from the scientific community. But one that we kind of tended to all to agree was that the paranasal sinuses played important role in the decreasing the weight of the skull. So taking some of that mass away, remember carrying the head with a thin neck, that's a lot of work. So anything that we can remove from the weight there makes sense. The other thing that we have pretty, I would say, strong evidence for is the role of the sinuses in the voice resonance, a further alteration of the voice that gets started at the level of voice box. We can see that these sinuses play an important role in that as well. The third one that was a little bit more controversial, we talked about how the very front of a car is designed to collapse in an accident to absorb some of that force, so we don't get that strong of an impact on a traveler, on a passenger. So we were wondering, could that play similar role, these paranasal sinuses, in a human design? So could it help us to absorb some of that shock if there's a face-on collision or hit that takes place? So we're able to absorb some of that. We remember that wasn't totally supported by everyone yet. So that's something where a little more work is being done to see whether we're convinced or not with that. And the fourth one, when we talked about the immune system, we saw that there's a lot we don't know yet. And that's true also with these structures. They might have a role in the immune system functions that we just fully do not know, do not necessarily fully appreciate yet. So we don't want to rule out anything that we're not 100% familiar with. And having gone through those, I think that it's a good time for us to have a look at this image that we see here. We see the inflammation of the sinuses, paranasal sinuses here. I believe this is a CT scan. And here actually we see complete opacification of the right maxillary sinus. This is a CT image without a contrast. So it really shows the extent there. There is some risk of overdiagnosing with this imaging technique, so some care needs to be taken that we don't jump right into conclusions too drastically. But I think that both of these are really good at highlighting these major what we can see signs of the sinusitis. You, of course, remember itis in medical language was an inflammation of something, and it's going to be now inflammation of sinuses. One discussion that I do like to have with my students when we look at these pictures or similar pictures is that why are we using CT scanner, not MRI, when we're trying to find evidence of the sinusitis? Well, remember that MRI is not ideal really for the bones and mucous membrane contrast. It's rather about separating the soft tissues from each other. So really for that reason, really probably the CT would be the preferred imaging modality to use. So we can now, having looked at these, return back to a view that we've seen before. So let's return to this mid-sagittal dissection and have a look at a few of the other things that we can see here. And I think we should start with our, I'm trying to think, what should we go through first? let's go through first with our epiglottis that we can see here. So this flap-like structure. This flap-like structure depresses during the swallowing so that we're covering the trachea, so that we're not getting food or liquids going down the lungs. We want the trachea, though, the airway, to be open as much as possible. So securing the air supply to the lungs is going to be important. So that's going to be our priority at all times. We do see more posteriorly and our esophagus. I think you Americans spell it without O at the front, just with an E. So you'll notice how esophagus is typically, when it's relaxed, not induced, kind of squashed close, whereas the trachea was kept open. Some of the good structures to notice there, and they actually bring us to have a look of the next structure on the CT that I have a picture here, and we should probably ask, what do we see here? What's the structure that I want us to focus? And it is gonna be our larynx, so our voice box that we should look at. And a couple of just let's orientate ourselves and get ourselves clear where we're at. We notice starts at the hyoid bone here at. We can see the hyoid bone also here on these diagrams that we have from the front and side view in addition to this CT. This is the highermost, the uppermost part of the larynx, kind of a U-shaped structure, if you wish. Commonly broken when a victim is strangled. So it is one of those things that we look for, not definitely black and white, clear that always when it's broken, someone has been strangled, or you can be strangled without that breaking. But one of the things that we look in forensic work, it does provide us an attachment point for the muscles of the floor of the mouth. So an important one in that sense. And what we're going to be focusing on, the cartilages that make up the larynx. So I think that we can do a quick run through those, kind of revising stuff that we have learned. And rather than using, we can see the cartilages on a pale color here on our CT picture as well. Wonder why my screen every once in a while goes crazy. But we can see these cartilages, but we're not going to use this picture. We're going to use these diagrams that I've drawn for you. But if we had time and a little bit better screen, we could see the very same structures by studying this in a greater detail. So let's jump onto this and start with our thyroid cartilage. So this largest, most pronounced portion of the laryngeal cartilages. There's one of these, doesn't fully close from the back, so it's kind of more of a U-shaped if you look at it from the top down. So gives us a view from the back in there. A few structures that are very prominent there. We see this projection most anteriorly. You might probably know it as an Adam's apple. So the proper term would be our laryngeal prominence. This is also above where the thyroid gland would be located. So we talked about the thyroid gland on a few other chapters, and we had a look of that also in the class. The next one that I want to talk about as a revision is going to be our cricoid cartilage. So it's going to be our kind of only laryngeal cartilage that fully forms a closed loop or circle of these. So something to keep in mind, kind of cricoid ring, if you wish. It is the lowermost part of the larynx and functions as the back of the voice box, really. So attachment site for many muscles, cartilages, ligaments that are involved with the opening and closing the airway and producing the speech. When they do have to put in a breathing tube in surgery, anesthesiologists would push cricoid cartilage to close off esophagus so that we're preventing the gastric reflux, so the backflow from the stomach. So that's, again, skills that are a little bit more advanced from what we're doing on this introductory class, but something to put at the back of your mind that you might run into later when you get to the clinical skills. Another structure that I want to talk about is our epiglottis. So this flap-like structure, we see it nicely on this view from the halfway through. We see it poking from behind of all of these connective tissues on this view as well. Epiglottis. So if you think of the name, what does the name tell us? It tells us that it's above the glottis. Glottis was the space between the vocal cords, so this opening space. And this includes, for example, the epiglottic cartilage, which is then covered by mucus. It is open most of the time. Remember, we want the air passage to the lungs to be our priority, to be secured. So it only closes when we are swallowing to prevent liquids or food going down the trachea. But securing the open airway is going to be the priority for us. We can also see our arithmeoids. So arithmeoid cartilages, these kind of pyramid-shaped structures, if you wish. Three-sided pyramid, there's two of those, one on each side. At the posterior point for the attachment of the vocal folds, and we can see the vocal folds quite nicely here. So this is how, by moving the arithmeoids, we're able to manipulate the tension of the vocal cords as well. There is an arithmeoid muscle that controls these. So something to put there as a note. We do see corniculate cartilages, these tiny tips on the very top of the arithmeoid there. Sometimes they can be fused with arithmeoids. And the last structure that I wanted to show was this cuneiform cartilage. It's kind of getting hidden with all of the other drawing that I did, but you saw it on this dotted line, kind of colored with yellowish color on this diagram. Cuneiform comes from Latin, means wedge-shaped, so kind of elongated pieces of elastic cartilage inside the mucous membrane. Their function is really to support the vocal cords and give the structural support to this soft wall. So those are the major cartilages of the larynx that I do want you to know. I think it is going to be useful for us, rather than just looking at a diagram that I've drawn for you, to see some real dissection views, kind of from various angles, and dissecting them a little bit further and a little bit further. So let's just highlight some of the things that we can see here as well. So we see our thyroid cartilage, the largest cartilage, kind of taking the majority of the view. Here we can see the laryngeal prominence, our Adam's apple, nicely. What else could we see? We can see our epiglottis. So that's going to be continuing behind there. It's peeking out here as well. On the posterior view, it's kind of a prominence. So what else? We see our hyoid bone. So the side view and the front view, we talked about that when we started talking attachment point for the muscles of the bottom of the oral cavity. Cricoid cartilage showing up nicely, the only fully fused ring that we see here. And we see our trachea. With the trachea, notice we see these rings that are a word of talking a little bit about these tracheal cartilages. Notice how they don't close all the way to the back. So they're more of U-shaped in structure. So that's our trachea. And if this is anterior and this would be posterior. And this was because we had our oesophagus here. So oesophagus might have needed space to kind of little protrude inside the trachea as well. What else could we see? I'm trying to scan that picture. We probably should remind ourselves. So of course we have the oesophagus running posteriorly. So the epiglottis close the trachea, the airway, so that the oesophagus can then pass the liquids, foods that are going on there. I don't think there's too much more there. This is a really nice posterior view of everything that we've seen. We see our arithmeoids and corniculates nicely there as well, when we've taken really away of the pretty much everything else that the cartilages and some of the, we've left some of the connecting tissue just to keep them together. Here.
Now give me a singing. The low pitch and then sing up. Now high to low.
So I'm gonna jump out of that video. I was hoping to be able to pause it. So I'm just gonna talk about that a little bit with you. What we're seeing here is actually a video acquired with laryngoscopy. So the camera goes down the throat and we could see here, I'm trying to find a really good view. We see our vocal cords. So notice that how there's no blood supply to this tissue, so it shows up kind of paler in color. They come together and vibrate very, very fast when singing or speaking. They are actually so fast, the vibration, that you can't really see it on the camera here. So that's why it looks like it's almost like they would be moving on slow motion. The higher you sing, the more stretched out your vocal cords become, and the lower you sing, more relaxed they are. Remember though, that even though the voice production starts here, the further processing takes place at the level of the mouth. What else we could see? We could see the epiglottis peeking out every once in a while at the bottom of the screen here, quite nicely. Really something that you need to be pretty comfortable with getting the images taken. I'm gonna try to mute and go back to our view here. So we can see, like I said, our vocal folds. We could see the epiglottis, the flap here and there. A lot going on in there. I also have shown some X-ray and some CT images of the larynx, showing also our arithmeoids, our cricoid cartilage, and so on quite nicely here. So I think there's a lot to be seen there. What I want to do next is to move on to this picture so we can talk a little bit about the respiratory tree. So this image is acquired with bronchography. That's an X-ray of bronchial tree after it has been coated, coating the airways with a contrast agent. These days, we rarely perform this method. It has been made redundant by improvements in this CT imaging and bronchoscopy. But what can we see here? Some of the structures that we've talked about. We see the carina. You remember the division point of the left and right primary bronchi. from the trachea. So this kind of a peak, especially when you put a camera down, that points out nicely there. We see the primary and the secondary, tertiary, so on onwards, branches of the bronchi, intralobular, terminal, and respiratory bronchioles. We can kind of see some of that as well, not that clearly on this picture. What I have next might be a little bit of a gruesome picture for someone, so please, please, please do not get too upset. If you feel queasy, you might want to look away. Here what we're seeing is actually a vet surgery of a dog and dog trachea. So remember, the trachea was ciliated, so it had these little hair-like structures at this top of the cells, ciliated mucous membrane. There's less cilia as we move further down on the respiratory tree. The amount of cartilage goes down further you move down the respiratory tree, and the amount of smooth muscle then increases further you go down the respiratory tree. I sometimes get questions about this picture, so I guess that I could discuss it a little bit with you. It is common in small dogs that the tracheal rings become progressively weaker, and the composition of the cartilage in these becomes dysfunctional, so it is possible for the trachea to collapse in especially smaller dogs, so we might need to do surgery if the medicines don't work and the prognosis post-surgery is good. This is really not a problem on humans though, so I just wanted to throw it in there as a comparative anatomy, but not something that you need to worry too much about. We have covered a bunch of anatomy. I do want to talk a little bit about the physiology, even though we didn't get too far into it in our lecture. And for that purpose, I have actually two separate graphs that are going to be especially important for us to have a look of. And you will find that these graphs are also covered in your revision sheet. So this might be a good time to try to fill it a little bit, or we can do it together in a class as well. So let's have a look at some of the important things that I really want to highlight out of this graph that we can talk together. So this first graph on the left-hand side of the screen shows the 4 phases of the respiration. And let's start with the pulmonary ventilation. So the phase of pulmonary ventilation really refers to exchange of the air between the atmosphere and the lungs. And I've drawn this alveoli here. That's as far as we go in the pulmonary ventilation stage. And of course, you'll notice that we are bringing in oxygen from the outside air to the lungs and to the very end of them at the alveoli, and taking away carbon dioxide from the lungs to the outside air. So that was our first phase of a respiratory process. The second phase is gonna be our external gas exchange. So there's going to be 2 places where gas exchange takes place. And we're going to start with the external one of those. And by that, I mean that it is the first, it takes place between the alveoli, so the very end microscopic sacs of the lungs, and then the capillaries of the pulmonary system. So what we are exchanging here is going to be that we're exchanging the oxygen and carbon dioxide between the blood in the pulmonary capillaries with the alveoli of the lungs. So oxygen into the blood, carbon dioxide out of the blood. The third phase that we might talk about is going to be our our gas transport. And the thing to notice here is that the transport of the gases in respiratory phases is through the blood. So the circulating blood supply of oxygen to the tissues and bringing back carbon dioxide to the lungs. That forms the third phase of our respiration. We have one more phase left, and that's gonna be our internal gas exchange. So again, we're exchanging gases between the capillaries of the systemic circulation and the cells or the interstitial fluid of the systemic circulation tissues. So oxygen to the tissues or to the interstitial fluid, and carbon dioxide away from the tissues to the capillaries of the systemic circulation. And you remember that this was all to do because of our cellular respiration, and we'll kind of revisit this theme in just a second. But to make energy that your cells can use, we use nutrients, but we do need the oxygen and we do need the carbon dioxide. So that's why we need to have the phases of respiration, providing these to the cells and tissues. The other picture that we're seeing here is another physiological concept that I want to talk about, and we didn't really get yet in a class. I'm probably gonna cover it during our lab time, just kind of as a crash course. What we're seeing here is the gas exchange both at the pulmonary circulation and at the systemic circulation. And the exchange of gases is really due to the partial pressure differences. So, and we can do some math, and I'm not gonna bore you with the math. You can just take my word for it, or you can hear the full math in the full lecture videos. But what we see is that there is a difference in partial pressures of concentration of oxygen and concentration of carbon dioxide within the blood and within then the lungs or the tissues. So the partial pressure of oxygen in the air around us is about 100 milligrams of mercury, whereas the partial pressure of oxygen in the blood as it returns from the systemic circuit to the lungs is 40 milligrams of mercury. So you remember we always had this passive diffusion from areas of high to areas of low. So of course the high will be now the alveolus of the lung, and the blood will be the low. So oxygen will be moving from the alveoli to the blood within the pulmonary capillaries. The direction is different because of a differing partial pressure concentration. So the partial pressure concentration of carbon dioxide in the air around us is about 40 milligrams of mercury, whereas it is about 45 milligrams of mercury as it arrives from the systemic circulation to the lungs. So remember, from high to low, and the direction will be, in this case, of course, from the pulmonary capillaries to the alveolus for the carbon dioxide. So that's how, really, when we leave the pulmonary capillaries, leave the lungs and head back towards the heart, the concentrations of oxygen and concentration of carbon dioxide is gonna be matching that with the air around us. So that's how we oxygenate the blood and we get rid of the carbon dioxide of the blood at the lungs. Let's have a look at these same events within the tissues of the systemic circulation. So we remember that the blood that's coming now is going to have a high partial pressure of oxygen, so 100 milligrams of mercury, whereas in the tissues it's only going to be about 40. So again, from the areas of high to areas of low. So the oxygen is going to be moving away from the blood in the systemic capillaries to the tissues. So it's this partial pressure difference that's driving this exchange. The direction is going to be opposite. If we look at the partial pressure of the carbon dioxide, 40 in the air around us, and therefore in the blood that's leaving the pulmonary circulation, 45 in the tissues. So from the areas of high to areas of low, carbon dioxide is going to be picked up by the blood in the systemic capillaries and then transported to the lungs. I hope that that makes sense and kind of clarifies a little bit the importance of these basic concepts that we have covered in our Bio 181, Bio 182, and so on, of having a look of the movement of materials due to diffusion. And that brings me to just highlight the control of respiration at the level of the central nervous system. So it is the medulla is gonna be medulla oblongata, the main control center, and pons then further modifies the respiratory processes. You remember both of these structures are of course part of the brainstem. So brainstem, very basic vital functions, evolutionary, the most primitive first to develop, but so breathing has been an issue, vital importance early on our development of life, but also in an individual's development. Brainstem is one of the first structures of the central nervous system to take place. So cardiac control, respiratory control, all of these things are maintained there. This is driven by receptors that detect the changes in the blood chemistry, so oxygen and carbon dioxide concentration in plasma, stretch of lungs, cerebral spinal fluid, hydrogen concentration. So we're all the time analyzing those by various receptors. You remember that we talked about the homeostatic feedback mechanism loop, so this would tie into there really, really, really nicely. Really, the last big concept that I want to talk with you guys relates to kind of putting it all together. What is happening in life? What is it that our body really does? So let's have a look of that a little bit. And I'm just writing chemical formula of a glucose molecule. So that's going to be symbolizing the nutrients that we're going to be talking about. And what we do with the glucose, with the sugars, we break them into ATP. So you remember that was the cellular energy currency. That's really why we need to eat. So we get energy for cells to do their stuff with ATP. As a byproduct of this process, we are left, and I'm not balancing off this equation. I'm not even including all of the things. I'm just including what is important for us. We're left with carbon dioxide and also water. Well, this carbon dioxide and water are going to be a problem for us now. We need to be able to process the carbon dioxide and the extra water that results as we do what our body does the best, so exchanging or breaking energy, breaking nutrients into energy that we can use as ATP. So we get to an equation that's going to be rather interesting here. And I'm not asking you to memorize the equation, but it is useful that you understand where this all is coming from and why this all is important. So our carbon dioxide and water from metabolism can be converted into our carbonic acid. And carbonic acid is really how most of the carbon dioxide is being transported as. And carbonic acid instead then can be converted into hydrogen ions and are bicarbonate. So most of the carbon dioxide is transported to the lungs as a bicarbonate, and then we can get rid of the carbon dioxide with respiration at the lungs. The hydrogen ions typically are urinated out in the process of urination. So that's a way to get rid of them. So really this shows how all of these systems that we have been talking about are connected. So we need to have our digestive system to get the energy, get the nutrients. The goal of that was to make ATP, but we're left with the byproducts of carbon dioxide and water. Carbon dioxide and water, we need to get rid of them somehow. This is where the carbonic acid equation comes useful. The hydrogen ions, we urinate those out largely. We'll talk about urinary system in the next week's chapter. And the carbon dioxide transported as bicarb to the lungs so we can breathe that out. So all of these systems are really interlinked. There is a connection. So I really am not a biggest in favor of looking at systems system by system, but that's what we're doing on this setup of the course. But I want you to see how everything's connected. We should talk a little bit about aging. So what happens as you age in terms of the respiratory system, the cilia that line the trachea, they become less active. Mucus tends to become thicker. We do have less effective macrophages in the lungs to clean the lungs. Elasticity is lost, so it becomes harder and more rigid. These structures that used to be very elastic, bronchi walls become thinner and tend to collapse. Reflexes tend to slow down, so swallowing, gagging, coughing. There's possible issues as medical conditions with that. We are more likely to get respiratory infections with the aging. There's more dead space in the lungs. Breathing is less effective, and exercising is not as well tolerated either. So really, if I look at what I set us out to do, I think we're doing a fairly good job of meeting the intended learning outcomes. We didn't dive into too much of the physiology during our class time together, but like I said, the lab time allows us then to tackle a lot of that. And I hope that you have found this session useful as a kind of a different way of approaching this chapter content. As always, I'm here to answer any of your questions, so don't hesitate just to reach out to me and we'll tackle them. We'll work through them together, and we will also see tomorrow in an in-person class. I thank anyone who joined me on this recording and anyone who joined me in person, and there will be another session later today on the in the afternoon or in the evening that I'll be also providing. I hope you have a very good rest of the day, and I'll see you tomorrow in face-to-face class.